The broadcast is now starting. All attendees are in listen-only mode.
Okay, good morning, everyone. I want to start off with a discussion of the composition of the Plan Management Advisory Work Group. Since we had everyone submit their applications, we've been going through those, and just want to give you an update before we hand it over to the presenters today. So we appreciate when people return. Sometimes people don't have time, and if they may not have time to continue as a full member, they can always contribute as a member of the public. So I want to let you know that most of our people are returning, but there are a few who are not. One is Hector Hernandez Delgado, who has been with us for one cycle, I believe, and he will still contribute, just not as a member. Another is April Martin, who has been with us for a very long time. And I appreciate all the contributions she has made, but she can continue as well if she wants to. And then I'm going to hand it over to Rob for the next person to talk about.
Well, that's me. After a couple of years as chair of this group, I'm honored to move chairs to the back of the room and hand it over to other of my esteemed partners and colleagues in the consumer advocate, health plan, and provider and Covered California community. So I'm grateful to have had the opportunity to learn so much and partner with everyone, and I continue to look forward to doing the good work we're all doing, but just from a chair in the back of the webinar room.
All right, thanks, Rob. I appreciate all you've done. So I do want to mention that we have some vacancies here to fill. So with Rob stepping down, we will have Marcy Reeder stepping in as a representative of Blue Shield. You should all know her pretty well. She's been contributing for years as well. And then we have a couple more slots still open. We have some people who have applied. We have not determined who of the applicants we're going to bring on board yet. So hopefully we will have that resolved by next month. And then we do have a vacancy for the chair, and I've asked Rick Crum to take over the chair position, and he, Rick very well. He's been very engaged as well over the years, and we'll keep the discussion going as well as Rob did. So, before we move on to the next item, I do want to remind you that we are interested in your ideas on topics for future meetings. Now that we're pretty much wrapped up all the contract discussions that have consumed us for the past 2 years at least. And as long as it makes sense in the context of what Covered California is doing, all ideas we are interested in hearing about, and we will review in a future meeting, maybe set up a calendar so that you know when to attend if you have a limited schedule. So with that, let me hand it over to Sana, who can go over the attendees as typical, and then I will hand it over to Rick.
Thank you, James. And good morning, everyone. Currently, for the committee members, we have Amy Frith, Carolyn Sanders, David Brabender, Emma Hu, John Newman, Marcy Reeder, Rick Crum, and from the board, Covered California board, we currently have Jerry Fleming online. Thank you.
Great. Thank you very much for going through that. And James, thank you very much, and the Covered California team for your belief in me. And Rob, thank you for your leadership over the last several years over this committee or work group. And for everyone participating, both the panelists as well as the public participating, really look forward to the continued partnership amongst all of us as we keep moving this forward. So, and Marcy, I'm glad to see that you'll be carrying on for Rob as a panelist here, and look forward to others applying and as Covered California reviews those applications. And with that, let's go ahead and get started. I think Elena, is that going to you for the QDP update?
Yes, thank you so much, Rick.
Thanks.
Good morning, everyone. This is Elena with the Health Equity and Quality Transformation team. Before we review the comments received and proposed changes we've made, I want to take a moment and thank this group and our dental refresh worker for all your comments and feedback. We appreciate all of you for the progress we made, and today we'll be reviewing the final proposed changes to Attachment 1 and Attachment 2 before we take this to the board next week. I also want to take a moment to express our appreciation for all the questions and feedback we received regarding the adult preventative services utilization measure. We are working through those, and we will release an updated draft soon. So with that, I will walk us through the Attachment 1 comment themes here. So for Article 1 and Article 2, we had a consumer advocate submit some comments here. So for equity and disparities reduction, they requested to have annual reports for disparity reduction and cultural and linguistic requirements made publicly available. I do want to note that existing contract language already allows for reporting out elements of contractors' progress reports for that item. For population health here, the comment was they expressed disappointment that requirements have been narrowed for only a specific or a select group of populations rather than all members, and that the population health management plan and strategy requirements have been removed. Again, Covered California has prioritized vulnerable enrollee populations in the initial contract requirements as dental plan issuers and dental providers expand these capabilities. And again, we're committed to supporting QDP issuers in developing comprehensive population health assessment and management strategies as time progresses here. So on the next slide, Article 3, Health Promotion and Prevention. Again, some comments here. A consumer advocate has expressed disagreement with the removal to report the requirement to report the number and percent of Covered California members who complete recommended preventative services and treatment plans. They recommended a minor language change to ensure that all patients should be screened and referred for tobacco use. And then they expressed disagreement with the removal of the proposed requirement to report the number and percent of Covered California enrollees who use tobacco and pregnant Covered California enrollees with periodontitis. And then issuers recommended removal of tracking and reporting of pregnancy, as dental practice management systems do not support this requirement. So on the next slide, I will go over the notable changes to Article 3, Health Promotion and Prevention. So the first change here for 3.01, dental plan benefits and services communication, we added added language that Covered California will be monitoring activities to establish and maintain a robust set of utilization metrics. The rationale here is that utilization metrics can be used to ensure adequate oversight of adult utilization and engagement in care. For tobacco cessation, we revised language to reflect all enrollees should be screened and referred for tobacco use. This is just clarifying our original intent. And then for 3.03.1 pregnancy, we revised language to define tracking. We recognize the limitations of current dental practice and management systems. I will move on to the next slide. These are our Attachment 2 comment themes. Again, consumer advocate expressed concern that all performance standards are related to utilization of dental services and additional measures should be included to assess outcomes. Expressed disappointment that preferred spoken or written language and ethnicity are optional or not required. And then we had some issuers provide some comments here. They requested adjusting the weight of percentages between AGI data submission and provider directory submission, consideration to decrease the 10% improvement performance level, adjusting the weight of 4 oral health standards so that the adult preventative services is greater percentage than the sum of the 3 pediatric oral health measures, and then suggested not including pediatric sealant receipt of permanent first molars, excuse me for that, with the plan-specific relative improvement approach in considering lowering the percentage distribution for this measure. So on the next slide, some notable changes to draft Attachment 2. We have shifted percent at risk between pediatric and adult oral health measures. We recognize the majority of QDP measures are adult, and have adjusted the percent at risk to reflect that distribution. And then we added language regarding the 10% improvement performance level. The language reads as Covered California will consider adjusting the proposed 10% improvement performance level if appropriate once AGI data are analyzed and baseline rates are established. So we wanted to, before we move on to the next slide, we did want to note that we will be posting all specific comments and responses received for the QDP refresh on our HBEX page today. So again, these are just the comment themes and the notable changes, but all specific comments will be posted today on our HBEX page. And then I will pass it on to Taylor for the next couple slides.
Thank you, Elena. Good morning, everyone. We wanted to take a few moments and just talk briefly again about dental measurement. We did have, we've had throughout the rounds of public comments, a lot of really helpful engagement on how to approach selection of dental measures for this updated contract. And we've had some evolution in terms of how we are thinking through measurement for both the use of performance standards in attachment 2, as well as how we can use our HEI data and a broader set of available measures for kind of monitoring access and utilization of members. So we wanted to just walk through again, starting at the beginning, just a reminder for Covered California's measure set criteria. So this was initially established in our work updating the health plan contract. We, throughout our work with the dental contract refresh work group, we did not have recommendations around revising this criteria to apply to dental measure selection, though we'll talk in a few minutes about some of the limitations in the available universe of dental measures and how we might need to just apply them a little bit differently. So the way that we approached measure selection for our dental contract is really applying these priorities and these criteria. So we looked for measures that capture epidemiologically relevant measurement for conditions that are those key drivers for morbidity and mortality. We looked for outcomes-focused measures. There are definitely some limitations here in this area. We wanted to prioritize working with established measures to minimize administrative burden, both for the provider community as well as our plans, particularly plans that operate in more than one market or line of business. We wanted to look for measures that are actionable, where they clearly translate to actionable improvement, and those that are amenable to intervention by a plan or provider. We wanted to make sure that our measure set was parsimonious. So within the context of attachment 2, again, we are looking at a total of 4 measures, 3 pediatric and 1 adult. And then alignment is really important to us to make sure that our contracted plans and their provider networks are able to really focus and not spend a lot of time moving between measure sets by purchaser or payer. So on our next slide, just a quick note about the work we did over the course of mostly 2022 summer and into the fall of 2022, trying to build a working dental health measures inventory. So we looked at the DQA measures, the measures in use by Department of Healthcare Services for the Medi-Cal dental program. We looked at their work with the Dental Transformation Initiative at the DTI, and what measures were being used in CalAIM and the dental pay for performance programs. We also wanted to, again, looking at the epidemiologically relevant measures, we looked at the U.S. Preventative Services Task Force to understand where the evidence base was for clinical dental services. And then we also were paying attention to HEDIS's recent adoption of a couple of the Dental Quality Alliance measures, and then looking at measures included in the Medicaid adult core set. So there were limited measures to choose from in terms of those that met kind of one or more of our measure selection criteria. And we really want to be focused on application of those criteria, particularly looking at the strength of evidence, looking at the link to health outcomes, and prioritizing alignment at this point, but recognizing we will have opportunities to evolve our measures moving forward. So on the next slide, we did want to revisit. We have had consistent feedback around measurement and measure selection, which has been really helpful throughout the process. But we did want to take a moment and just revisit kind of the primary themes that we've heard over the course of the contract update. So there are a lot of moving parts, which is exciting. So we have seen movement in the CMS Universal Foundation, adoption of DQA measures, HEDIS adoption of DQA measures. So we do see movement, which is really exciting. Though the evidence for the clinical evidence for the adult population is definitely lagging behind the science and the evidence for children's measures. We were reminded often throughout comments and feedback that there is just also current limitations in terms of industry processes and technical infrastructure to do good data collection and to do comprehensive measurement. There are also financial and payment models in place that emphasize certain patterns of treatment that result in challenges for data collection, particularly on the DHMO side and collecting encounter data. And we need to be cognizant of, again, those lower premiums on the dental side, where it's harder to absorb the expense for really significant investment in data collection and improvement efforts. So the consistent suggestions and themes around how to approach these challenges is to emphasize increasing encounter data collection, being really attentive to monitoring data quality, focusing on health promotion, and really increasing prevention and utilization of services. We've talked a lot about how to apply our measurement criteria here, but starting with measures with a strong evidence base and working from valid measures. So I think we had one more slide here where we did just want to talk about for the 4 measures selected for attachment 2, where there will be performance standards applied. We did want to just summarize kind of the strength of evidence and the alignment for those measures selected. And I'm realizing we should probably have DHCS in here for alignment on the adult use of preventive services measure. So we will be sharing an updated draft measure specification for that adult measure. We are really appreciative of the really detailed feedback we got. It was really responsive to the specific questions we're posing, and we think we can have that ready to share in the next few weeks. We have had a lot of really thoughtful and helpful feedback on the challenges for some of the measures, especially the pediatric sealant measure. So a couple of comments that we wanted to make at this point is just to remind folks that there is a lot for us and our plans to learn as we get the dental AGI or claims and data into the AGI system and start to look at the level of data that we have, what the potential baseline rates will look like. And we are really committed to setting the measurement agenda and the performance levels at appropriate levels. So Elena spoke to the fact that we have now added language to attachment 2, that we will reevaluate the performance levels to see if they are appropriate based on what the scope of data looks like and what those initial baseline rates look like. We will absolutely adjust how we are treating the pediatric sealant measure if we need to. So again, this is a service that is received once in 3 years, and we in the plans may not have a good line of sight into where those services have been received if a child is switching providers or changing plans. And then we wanted to be really clear in the attachment 1 edits that our measurement approach is not limited to these 4 measures selected for performance standards. We will be able to use HEI data to generate and share out with plans and publicly report on a more robust set of dental metrics. And that is likely to look a lot like the DHCS measures in order to really assess engagement in care, access to care, and if we are seeing increases in utilization, which is the outcomes we are hopeful that our attachment 1 requirements will incentivize. I think with that, I'll pause and see if there's any questions. Hopefully this has been a little bit helpful just to share our thinking, our process, and our commitments to evolving dental measurement and our use of dental measurement moving forward.
And Elena and Taylor, it's Rick. I just want to thank you folks for all the partnership and working on this and this update. So thank you. Definitely open it up to those other questions and comments from others.
Thank you, Rick.
Taylor, we don't have any raised hands or any typed in questions. Thank you.
Thank you, Sana.
Thank you. We can transition to the Plan Year 2024 Standard Benefit Designs update. I wanted to thank everyone for the opportunity to speak to you again. And we're before you again today with some changes to Silver 70 and 73 plan designs. We had determined that there was an error in some of our calculations, and this required further modeling for these 2 plans. So in order to bring the AV back into range, we needed to target the Silver 73 first, and we evaluated 2 approaches to accomplish this. The first of which was to target the drug deductibles, raising these in Silver 70 by $30 and raising this in the drug deductible in Silver 73 by $40, while also increasing the ED facility fee by $50. A second approach was to target the medical deductible, but this required us to raise the medical deductible by $650 to $5,400 for both, and required increases of $10 and $20 to the 70 and 73 drug deductibles, respectively. This also still required increasing the ED facility fee by $50 in both plan designs. Based on these results, we are recommending Silver 70 Model P and Silver 73 Model L, as the change to the drug deductibles still leave us well below the drug deductibles in the pre-pandemic designs, which, for your reference, in 2020 were actually $300 for Silver 70 and $275 for Silver 73. I can pause here for comment. Sana, do we have any comments or any hands raised?
I think Amy may have a question.
Okay, great.
It might have been typed in there.
Yeah,
like
yeah, go ahead.
Yeah, if you could just repeat, sorry, it was Model P and Model L that were being recommended to the board, is that correct?
Yes.
Okay, thank you.
Yes. Okay, and so these are the, if we, unless we get further feedback, these would be our plan designs for 2024. We have included models P and L in the side by side, but are certainly open to comment and suggestions from this group. And we also wanted to briefly address a question that was raised at the last Plan Advisory Workgroup meeting around how restrictive illusory benefit levels are, specifically in the scenario of increasing generic drug copays to allow room in the AV to remove the deductible from primary care visits in the BRON designs. In consultation with our legal team and based on our research, Illusory benefit level restrictions would prevent submitting copays that far exceed the cost of a service or drug to the carrier. DMHC pointed us to the Health and Safety Code section 1300.67.24 on requirements for cost sharing, and they provided guidance to us that cost sharing must not be illusory and that the department reviews the cost sharing on a case-by-case basis based on the information provided from the licensed entities. As such, the guidance we received is that we should be mindful in setting cost sharing amounts. So do we have any further questions or comments?
Hey, Melanie, just a comment. Thanks a lot for that follow-up from that last meeting.
Sure. Yeah, thank you. Thanks, Rick. Okay.
Melanie, we don't have any further questions or raised hands. Thank you.
Oh. Thank you, Sana. Well, thank you everyone for your thoughtful attention to our plan designs. And the next step is for presentation to the board, the Cover California board. Thank you.
All right. Hi, everybody. This is Emery from the Policy Eligibility and Research Division, here to kind of walk through a continuity of care framework to implement through SB 260. So today we're really here to talk about this main question: should consumers keep their current health plan if available when they transition from Medi-Cal to Cover California? I'm just going to start with a little brief overview of SB 260 and our initial implementation approach. Provide some background data that gets to this continuity of care question, and then really walk through some considerations that Cover California is thinking through on drafting this framework, and some feedback that we are requesting from you all following this meeting. I can go to the next slide. Next slide. So as many of you likely know, because this was presented to the board meeting a few months ago, SB 260 is legislation that directs Cover California to automatically enroll individuals losing their Medi-Cal coverage into subsidized marketplace coverage if they are eligible. This really here to talk about this main bullet, the second bullet today. Individuals will be enrolled in the lowest cost silver plan unless Cover California has additional information that enables us to enroll an individual with their previous managed care plan. This enrollment is supposed to occur before the end of their Medi-Cal coverage, and then consumers have until the end of their first month of coverage to make their first premium payment. We're also required to provide some information to consumers following this automatic plan selection, namely the right to select another plan available to them and the deadlines they have to make that choice. Next slide, please. So our implementation of SB 260 and this automatic enrollment program is lined up to coincide with the end of Medicaid's continuous coverage requirement from the pandemic. So this continuous coverage requirement is set to end at the end of March because Medi-Cal has been pausing redeterminations throughout the pandemic. So beginning in April, DHCS will begin outreach to consumers who have a redetermination date in June. And so at that time, consumers will have their eligibility redetermined. If they lose their Medi-Cal coverage, Cover California will automatically choose a plan for them set to begin July 1st. They'll receive a notice about this new plan in June, and then consumers have until the end of July in order to pay their first month's premium, or they have an additional 30 days of their special enrollment to come back in and choose another plan if they wish to do so. All right, next slide. Next slide. So here is the actual legislative text that we are focusing on today. The exchange shall use available information to enroll individuals into the lowest cost silver plan unless the exchange has information from either the county, DHCS, managed care plan, or another plan that enables us to enroll an individual with the individual's previous managed care plan within the time frame required. Next slide, please. So because of this options that Cover California have, we could either do the lowest cost silver plan or align with a managed care plan. However, at present, CalHERS does not contain information about an individual's managed care enrollment. We really only have access to the eligibility data, and at present, Cover California does not have another way of accessing this information. When SB 260 launches at the end of May and beginning of June, Medi-Cal transitioners will be assigned to that lowest cost silver plan. However, through some consumer research, we have really tried to tailor the call to action through all our noticing and web experiences to highlight that consumers do have options. They can either keep their plan, they can come in and change and shop, or they can cancel. And we really do try to highlight the options available to them by showing all the carrier logos so that they can kind of recognize their managed care plan if it's available through Cover California. So here's some examples of these consumer notices. You'll see on the top left here is that consumer notice that individuals will initially get when when their plan selection is made for them. We have this co-branded logo between Medi-Cal and Cover California. This notice provides information on the plan we have chosen for them, really highlights the fact that we chose the plan that has the most financial assistance available, kind of introduces Cover California, and starts to lay out their options, starting like keep, change, or cancel, streamlined options there for them. With this notice, we will also be including a flyer, which are these colorful middle panels on your screen in front of you. This front page, again, has the co-branded logo, some information about the benefit designs, kind of co-pays, what they were expect to pay and how to use their plan. And then that keep, change, or cancel call to action that I've mentioned before. And at the bottom, we will display all logos for all QHPs available in the exchange so that consumers can kind of recognize the brands if that's what is familiar to them. And then on the back page, this is a little bit more of a terminology on how they can expect to use their plan, a little bit like deductible co-insurance terminology that might not be as familiar coming from Medi-Cal. We do have this QR code on the bottom that will lead them to a specific microsite where they can log into a tailored enrollment dashboard, which you will see on the right here. Also kind of have this keep, change, or cancel framework that I've been mentioning. It'll have information specific to the plan we have chosen to them, or if they would like to change their plan, we will highlight the logos of the plans that are available in their rating region. Next slide, please. Next slide. So here's a little bit of background data that we have been reviewing and trying to think about how we could potentially implement a continuity of care framework in the next phase of SB 260. So starting with some public data from DHCS, kind of looking at like what is the degree of overlap in carriers between the managed care plans and Cover California. Right now we see that there are 32 counties that have some degree of issuer overlap, either full or partial county offerings. And right now these are for 2023, so do not necessarily reflect the 2024 new contracts with DHCS and do not take into account sub-delegated arrangements within Medi-Cal managed care. There's also, degree of overlap within those counties. Most notably in LA County, most Medi-Cal beneficiaries are enrolled in a managed care plan that overlaps with a Cover California issuer. Next slide. So now taking a look at some of our Cover California data on Medi-Cal transitioners prior to the pandemic to see kind of what their plan selection patterns are. About 20% of individuals who gained eligibility for subsidized coverage through Cover California ended up picking a plan prior to the pandemic. And the distribution of plan selections by carrier really did track to our general enrollment trends. And then looking at metal tier, about 60% of these Medi-Cal transitioners chose a plan within the silver tier, and then another 20% chose a plan within the bronze tier. Among those who did select a plan within the silver tier, 60% did select the lowest cost silver plan available to them. These are statewide averages, and we do see some degree of variation at the region and metal tier level, which we can take a look at the next slide. So here's just example data from 2019 showing information on plan selections by rating region and the distribution of those plan selections by carrier. So to take rating region 1 as an example here, we see that 20% ended up selecting a plan, or 20% of Medi-Cal transitioners selected a plan. And among those 20%, 56% chose a plan with Anthem. This is not specific to metal tier at this point. And then another 40% with Blue Shield, 5% with Kaiser. These blue boxes do represent which carrier was the lowest cost silver, or which carrier offered the lowest cost silver plan in that year. So you can kind of see that people did choose plans more often with the lowest cost price position. And then looking at the next slide, this is the same format, but instead focusing on the plan selections among Medi-Cal transitioners that specifically chose that silver tier. So this time taking rating region 2 as an example, among all 14% of Medi-Cal transitioners that chose silver plan in rating region 2, 83% did choose Kaiser, which was the lowest cost silver plan available to them. So this good data kind of enforces that, we're happy that people are choosing the silver tier, but they are still choosing some of the lower cost carriers available to them. Going to the next slide, please. So this is all, sorry to go through that pretty quickly, setting the stage for some of the considerations that Cover California is thinking about in terms of how to implement some sort of care continuity framework through SB 260. So currently, Cover California has 3 main buckets that we are kind of reviewing, one being the overlap between issuers and provider networks between Medi-Cal and Cover California plans, the trade-off between cost and continuity for consumers, and then, of course, some operational requirements for us. Go to the next slide. Okay, so starting with issuer and provider network considerations, of course, not all Medi-Cal managed care plans offer coverage through the exchange, so not all Medi-Cal transitioners will be able to retain their Medi-Cal managed care carrier through the marketplace. So we're only talking about a subset of consumers, as we saw with that slide, about only 32 counties having some degree of carrier overlap. And then, of course, for the carriers that do overlap between Medi-Cal and Cover California, there's not necessarily a guarantee that their provider networks will be the same between the 2 offerings. So any sort of change to map an individual to their carrier that corresponds to their managed care plan does not necessarily guarantee the continuity of provider, which is a really core intention here for trying to improve continuity of care. So given these things, like what factors should be considered when developing a care continuity framework through auto enrollment? Should we implement some degree of overlap requirements in provider networks between the managed care and Cover California networks? And should carriers be expected to provide some member level support in order to transition the care and provider for beneficiaries who are switching coverage? Okay, and now switching to cost considerations. We know that the continuity plan may cost significantly more than the lowest cost silver plan, depending on a variety of factors, including year, region, carrier price position, and a consumer's income. This fact is made even more apparent or concerning, I guess, with the implementation of the American Rescue Plan and Inflation Reduction Act that drastically increase the amount of subsidies that consumers are getting. So we took a look at our historical Medi-Cal transitioner data and applied the new subsidy structure to these consumers to kind of understand how many of them would be eligible for a $0 plan. And we see that this is about half of all Medi-Cal transitioners, including all of Medi-Cal transitioners who have incomes less than 150% of the federal poverty level, and more than half of consumers with incomes 150 to 200% of the federal poverty level. And that bucket really represents the core, or the largest subset of Medi-Cal transitioners. So we want to be particularly attentive to their price sensitivity. So go to the next slide. So we take a look at this using an example of a 40-year-old in Sacramento making just under 200% of the federal poverty level, which is about $27,000 a year. Under the current SB 260 implementation framework, they would be selected into the lowest cost silver plan, which is this Blue Shield Silver 87, costing them about $25 per month. However, if we were to map them to another plan, say Anthem, they would pay $55 a month, about $30 more in order to maintain that continuity between Medi-Cal and Cover California. But you'll see there is a wide range of prices depending on what their managed care carrier was. So then going to the next slide. This is the same kind of framework here, but this time focusing on someone with an income less than 150% of the federal poverty level. As you guys are very familiar with, they will be eligible for 2 $0 plans, including the one that they would be auto plan select into, that Blue Shield Silver 94. And so then if we were to map to a different plan based on their managed care carrier, they could pay $10 to $160 more a month. And the difference between $0 and $10 may not seem significant, but for these low-income consumers, we do, want to consider that the introduction of a price barrier may lead to concerns about take-up. And as much as we want to promote continuity of care, we do want to prevent any gaps in coverage as well. So those are some examples from our data, and then we also took a look at the research to see what do we know about consumers' priorities between price and provider. And we see that the evidence is pretty mixed, depending on the study. Here we have 4 examples highlighted for you. One study coming out of Massachusetts among low-income individuals saw that higher premiums were associated with decreases in enrollment. A study using our own data prior to 2016 showed that Cover California enrollees tended to select lower cost bronze and silver plans, which does kind of track with the Medi-Cal transitioner data that we walked through earlier. And then also looking at data from Anthem's exit from Cover California, over half of enrollees that were placed in the lowest cost issuer in their metal tier ended up switching to a higher cost issuer. And then looking at an example among Medicaid beneficiaries in New York who were randomly assigned to a narrow network, they ended up using fewer services and were more likely to switch to a plan that included their prior provider. Next slide, yeah, okay. So our final group, bucket of considerations here is our operational concerns. So as I mentioned at the beginning, Cover California must perform the plan selection before the end of a consumer's Medi-Cal coverage. And as said before, we don't currently have the data available in our system to make a plan selection based on the managed care enrollment. So some sort of data feed would need to be incorporated into our auto plan selection framework in order to achieve this. And so just as a reminder, as our system is currently built, the auto plan selection does happen in real time as the eligibility transaction occurs through CalHERS. And all of our consumer messaging does kind of highlight that the plan we chose for consumers is the plan with the most financial assistance available. So we would kind of have to update how we are messaging to consumers, how we chose this plan for them so that they know why that decision was made on their behalf. Okay. So a lot of areas to consider here, and I'm sure you guys have more thoughts. So we are requesting your feedback on all the information covered here today. In particular, how can carriers facilitate care continuity if we were to enroll a transitioner into their prior Medi-Cal managed care plan? What other factors are important to you all when considering the trade-off between continuity and price? And should we be thinking about any additional factors beyond provider network and premium price? I can pause for comments or questions, but we are requesting any written feedback to our policy inbox by the end of the month.
Thank you, Emery. We do have a couple of questions, and I'm going to start with Evelyn from Anthem. She has her hands raised, and I'm just going to go ahead and unmute her. Evelyn, please go ahead.
Hi, can you hear me?
Yes.
Thank you. I thought I had taken my hand down, but I will ask the question. When Covered California receives the immediate auto plan selection indicator, will Covered California release their welcome letter on the same day that they send the issuer the inbound 834 enrollment transaction? Or will they hold the welcome letter and release it 15 days prior to the requested effective date?
That is a great question. I am not entirely sure on the timing of the welcome packet. And if there's anyone from our noticing team or program policy, I would encourage them to jump in. If not, we can take that back and get back to you, provide a response at a later date.
Okay, thank you.
Emery, then the next question is about dental. Will this apply to dental, and would we know if individuals will also be auto-enrolled in a dental plan?
Yeah, at present, consumers will not be auto-enrolled into a dental plan.
Thank you. And then the next question is, somebody had a confusion regarding hospital being able to look up a person's Medi-Cal eligibility and plan through DHCS. However, CalHERS is not able to do that. So that's a question.
Oh, sorry, could you repeat that?
Yes, somebody wanted clarification on hospitals being able to look up a person's Medi-Cal eligibility and plan through DHCS. However, they just wanted clarification on CalHERS not being able to do that.
Yeah, so CalHERS, I hope I can answer your question. CalHERS really only combines the eligibility information from Medi-Cal, so the enrollment information of a managed care plan is not incorporated in CalHERS. So we cannot access that on our side. So it's definitely one of the operational concerns for implementing such a program and how we could get that information incorporated.
Okay, then the next question is, why is Kaiser the example Medi-Cal plan? Shouldn't the dominant Medi-Cal plan in the state with the largest number of members be illustrated?
Oh, sorry. For my example in Sacramento, I was just using a few different examples. We're considering, this for all plans that have some degree of overlap between Medi-Cal and Cover California.
Thank you. The next question is, has the reading level of these mailers been scored? They are concerned about the effectiveness of the high density of words.
Yeah, so I believe that we have, our noticing team has been developing these materials for quite some time. We did do a few rounds of consumer research in order to kind of tailor the message and address concerns that consumers had, and you're getting this new information, and the eligibility notices are based on a 6th grade readability.
Thank you. The last question, on SB 260, will cases with procedural Medi-Cal denials go through the SB 260 process? And they're wondering based on most recently issued CMS unwinding guidance.
I will have to check with my eligibility team on that. I do not believe they will go through the auto enrollment plan selection process because they will most likely not be eligible for subsidies. So in addition to being eligible for the exchange, consumers must also be eligible for subsidies, which does require some degree of information being updated and provided to DHCS during the redetermination process.
Thank you, Emery. We'll give the audience a minute to see if we have any more questions, any other concerns. If people want to ask any follow-up questions, please feel free to raise your hands and we'll unmute you or type in the chat, the question box. Thank you.
This is David Brabender. I had a question for you around the timing. Do we know, is Medi-Cal going to be doing redeterminations throughout the entire month? And is there any kind of a cutoff where that redetermination will take place like the following month? I'm really concerned that you're going to see the redeterminations in the latter part of the month. And by the time that notice gets to folks, they were already enrolled in a plan, and really, if they're going to be making any kind of changes, they're going to be in one plan for a month and then they're going to be moving over to another plan. It would be nice to be sure that they're going to have enough time to get to the plan they want before the change occurs.
Yeah, let me walk through the timeline as I understand it, and hopefully this will address your question. So the counties will be processing redeterminations based on the consumer's renewal date, and from what we understand, this will be happening throughout the month. But they have a 10-day notice cutoff, so discontinuance would occur at the end of the month if it falls beyond that 10-day cutoff.
Is there a way to have an earlier cutoff and extend it to the next month out? I mean, if they're waiting for a 10-month and then you're issuing the notice and the notice is going to take 3-4 days, I mean, you're going to give them 2 to 3 days, maybe a week to realize this is going on and go in and make a change if they want to.
Yes,
They
they have.
should be getting 30 days to really make a decision.
Yes, they have 30 days to make that first month's premium or pay that first month's premium or cancel their plan. And of course, the plan will be canceled if they do not take any action. And they do have an additional 30 days in order to come back in and make a plan selection after that.
Yeah. But you are realistically locking them out of any reasonable use of their medical for a month, because it is going to take them time to get a primary care doctor established, get a chance to get in, get medicines filled, right? So you're going to give them a notice 5 days before you make a change. They're going to be trying to figure out what they're going to do, whether they need to be in that plan or another plan. If they really want another plan, they're not going to have any access to care for up to a month other than potentially emergency coverage. I mean, these determinations should be made in such a way that before they're knocked off of their current plan and placed on another one, they've got a window of close to 30 days to review it and make a decision. Not that they're stuck in limbo, stuck in a plan that they didn't choose and having to evaluate and not be able to get access to care during that time. I just think they're not.
Yeah. Can you go back to, I think it's slide 19? Does that help address, David, some of the concerns that you've got in terms of timing and communication? Because I thought there was going to be various forms of communication between DHCS and Covered California, and one page past that, Emery, I think from that timing perspective, in terms of the advance notice to consumers beforehand to prevent those concerns that you're mentioning.
Yeah, I think that's right. You know, through this example, if someone has a redetermination date in June, DHCS and the counties will be reaching out to them throughout those April and May timeframes in order to encourage them to provide update information. And then if they do end up losing eligibility for Medi-Cal, they will receive, you know, a notice of action from DHCS. They will receive the notice from Covered California. And so if Medi-Cal determination happens at the last 10 days of the month, they won't lose their Medi-Cal the next month because they have that 10-day notice requirement, which I think gets a little bit at your concerns. And then when Covered California coverage begins, they are eligible to use services in that first month as long as they make that first month's premium. And then of course, if they would like to switch plans, they can do so prior to their Covered California coverage starting or within that their 60-day SEP window. I understand your concerns. I hope that timeline kind of clarifies some of them. So.
Yeah, it clarifies it, but it clarifies that they're going to be a fairly significant subset of folks who are going to get stuck potentially in a plan that they don't want to be stuck in. I mean, if I were aiming to do this the way I would have wanted it done, is any determination made in the month of June would see folks off of Medi-Cal at the end of July. Right, so that you're giving folks at a minimum 30 days, whereas right now you're giving them at a minimum 10. And that doesn't account for the mail getting to them. So really you're giving them a minimum of 5. I just think it's that there was a better way to do that.
Yeah, thank you for your concerns, and you know, something that we could take back to DHCS. Here we're just really, you know, this timeline tries to emphasize the fact that we are trying to prevent any gaps in coverage. So
yeah, I get that there's the gaps in coverage. It's just that putting them in a plan doesn't really give them coverage or give them access, because there's a whole process of finding a doctor, getting connected to that doctor, before you can really do anything in terms of getting your prescriptions reestablished, getting access to medicine, things like that. So it's going to take them time, and if they're going to be making a change anyways, it's just going to put them in a really tough spot. Whereas if you gave that month of lag, you'd have a chance for all of those notices to get out, and folks would really have an opportunity to take a look and make their selections themselves and kind of get ahead of it. So food for thought. Thanks.
Thank you.
April, please go ahead. I'm going to go and unmute you.
Good, let me go to my questions. When I didn't understand when it said that CalCheers can't understand which health plan the patient has under Medi-Cal. I didn't understand that when every provider I know can look up a patient under the Medi-Cal website and clearly discern who their plan is, and sometimes even discern who their IPA is. So that statement didn't make sense to me, and it sounds even worse because CalCheers can't really help connect people from one environment of Medi-Cal into Covered California at all in that regard. So I just didn't understand that statement from CalCheers.
Yeah, thank you. So CalHERS is our combined eligibility system for Medi-Cal and Covered California. And at present, as it's built, the enrollment information for Medi-Cal and that managed care plan information is not integrated into CalHERS. So something we are discussing and thinking about how to bring some of that information in, but there is two different data systems that you are referring to. And CalHERS does not have that in Medi-Cal enrollment information that we would need to do some sort of carrier alignment at present.
Okay, still makes no sense to me whatsoever, and I just want to urge you not to let perfection be the enemy of good.
Thank you. Yeah, we understand your concerns and are considering how to address them.
Yeah. I had two comments about the materials that I saw flash by. I am concerned that any illustrations of one plan over the other as a transition is going to be, how would I say, would be a tip for somebody about something and communicate things that are not necessarily so. So I don't know if you've formalized or printed your materials yet, but I encourage you to look at that carefully, especially when I see the diversity and non-match of Medi-Cal to Covered California plans. The presence of one logo over another can be vastly inferential and start everybody on the wrong assumption. So to me, I was concerned when I saw that, just because I know people will look at things visually first and intuit from that, and I didn't like the inference I saw. I also saw that there were a lot of words on these pages. I know that DHCS lives by words, but is there any way to simplify this, or at least have the reading score of these three pieces of material tested? Because I tried to pretend I'd only graduated from high school and just read it, and I felt confronted. And it's, to the degree it can be simplified at all with more simple messages, I encourage it. I know that we're discussing a very complicated problem, but I think that our duty is to try and communicate as simply as possible, and to rely on the rest of the experts who enroll people to help illustrate the nuances. I know you'll be good with DHCS on that one. And then I did want to just I just wanted to underline David Broadbender's discussions about access. If during this period of time for any provider who's either providing emergency services, which are mandated in all situations, or elective services, which can be deferred. It is very, when I look at this and understand how DHCS and communication occurs, I think there's a high likelihood that people are going to end up being misinformed as, well, providers will be misinformed as to the eligibility of the patients that they intend to treat for elective services. And I want to point out that for hospitals and physicians who are dependent on cash flows, whether that be from Covered California services or Medi-Cal services, that essentially this is acting as almost a blackout period in June and July, possibly August. And for those providers who are in a very, very tight cash situation, their answer about if they provided emergency services, chances are that their payments are going to be massively delayed because of this confusion. And that can endanger some very marginal providers and hurt the system even worse than it is today. The cash flow implications of what we have going on here in this transition could be deadly for some providers.
Hey, April, it's Rick. From that hospital perspective and the physicians, are they typically checking eligibility even for emergency services at time of service?
Absolutely. Speaking for Dignity Health, who I know best, we subscribe to the largest national database in the country, which then brings down eligibility, any possible eligibility, down into an overall look. And then Medi-Cal eligibility is also usually separately queried as well. So it is standard operating procedure to check eligibility in both sides. If the patient showed eligible in June and they really were, I'm sorry, it shows as eligible in July, and instead they've been cut off in June, that provider is not going to be paid from the managed, that provider is not going to be paid from the managed care organization. And likely the provider is the one who's going to hold the accounts receivable until all of this settles. Right now, there are a few very tentative providers in terms of cash flow across the
Sure. Yeah, I'd hope, thanks for confirming about the eligibility piece there. And definitely recognize the cash flow concerns that you mentioned. I'm just wondering, as a result of the processes of showing, eligibility start and end dates, et cetera, whether it's through Medi-Cal or, if a consumer selects their coverage, for those that need to pay, make that binder payment, whether that will assist resolve that concern.
Yeah,
in some way. I mean, I'd hope so.
I hope so, but it's not DHCS doesn't have a practice of showing future cutoffs. In other words, if that patient was receiving services in June, they would do an eligibility check not only through the national database but also through the Medi-Cal website. I have never seen a Medi-Cal website for eligibility show an advance cutoff for Medi-Cal, ever. Even though this process, which is affecting so many people, will cut off their eligibility. I think people are going to be very cautious in the month of June if this is the time period that's going to happen, because they may look at this and go, the HCS confirmed eligibility, and we know chances are it could be really, really wrong.
Sure. I really appreciate you bringing that. And, from a plan perspective, I really appreciate you bringing that up. I know I'll be taking this offline with some of our points of contact to see if there's anything further planned by DHCS, but and encourage others to do so. And I apologize, Covered California, if I jumped in ahead of time. There, just with any questions, comments you had to April's comments, this whole thread, though, really caught my attention. Thanks.
No, thanks. Appreciate it, Rick, for jumping in. Appreciate your insight.
Thank you, Rick. We are actually past time. We were ending our meeting early today at 11. We still have a couple of questions, so I am going to defer to you, Rick, and our attendees, obviously. If we want to continue them, we can take the questions back and respond to them individually. If you have further questions, you can also email at the policy@covered.ca.gov email. Rick, what are your thoughts on this?
Since the calendar originally said, I think for another hour, if folks are okay, just taking these final questions that you've got, Emery, and then we can close it out from there.
Yep, that's okay with me.
All right, so the next question is, does Covered California have any more specifics on the data dashboard that we are developing on SB 260?
No, at this time, we are still developing some sort of reporting framework that we will be providing, and updates to come soon.
Thank you. Next question, would you also auto-enroll members with unsatisfactory immigration status?
At this time, we are only enrolling individuals who are at present eligible for Cover California and for subsidized coverage. Given the current programmatic rules, that was they probably will not be eligible for auto enrollment.
Thank you. Will Covered California introduce the new Unwind SCP?
At present, we do have only the 60-day SCP, but as this slide notes, individuals with incomes below 150% of FPL can enroll or change their plan at any time during the year. And we are still reviewing federal guidance on updated SCP. We can provide updates at a later date.
Thank you, Emery. To follow up on David's question, and this is a question that we have typed in, isn't there an intentional overlap between Medi-Cal and Covered California for 1 month? If so, the consumer could still access coverage through Medi-Cal for the month before.
That is a great question, and I would have to confer with our program policy and DHCS experts in order to respond to that one. So I might take that one back and follow up. That's okay.
And then someone's requesting a clarification. As of now, Covered California is going to switch members to the lowest costing silver tier. However, they are looking into switching them into the same carrier that they have on Medi-Cal to Covered California. For instance, Kaiser Medi-Cal users would automatically go to Kaiser's Covered California plan. And this is not, I'm sorry, I'm having some technical difficulties with the questions.
That's okay, I can try to clarify. SB 260 will be launching in June, as this timeline shows. And in our initial implementation framework, we are enrolling Medi-Cal transitioners who have subsidy eligibility in the exchange into the lowest cost silver plan available to them, regardless of what their Medi-Cal managed care carrier was. So the impetus for this discussion today is, given the legislative authority for Cover California to consider what the Medi-Cal managed care plan is, should we adjust this framework to instead enroll someone in the carrier that corresponds to their managed care plan, even if this carrier is not necessarily the lowest cost silver plan for that consumer. So this is kind of setting the stage for discussion on the second phase of implementation, and what kind of considerations we should review in developing that framework.
And then just a continuation of this question, Covered California will not send any notices to members who do not qualify for a subsidy? That's a question. And will they only get an alert from Medi-Cal?
If a consumer is found subsidy eligible, they will not receive, or not eligible for subsidy, sorry. They will not receive all of the special noticing that we've developed. This is only for the subsidized consumers who will be auto plan selection. I believe that consumers who are found subsidy ineligible will still receive the standard notice. However, we are still reviewing what kind of messaging and outreach and noticing requirements we should be providing for these unsubsidized consumers. But the information screens that I showed today will not be sent to these unsubsidized consumers.
And then the last comment we have is that they wanted to clarify for everyone present that the SB 260 transitions happen on a rolling basis and not all at once.
That is correct. They will happen in real time as the Medi-Cal redetermination happens. So it's not some sort of batch process at the end of the month. So as soon as someone is found ineligible for Medi-Cal and eligible for Cover California, the CalHERE system will make that plan selection for the consumer.
Thank you, Emery. That was the end of all the questions that we had typed in. Again, we would like to repeat it that if anyone has any further questions, please use the policy@covered.ca.gov for any questions that they have regarding the SB 260 plan. Thank you, everyone. And I think that's the end of our session for today.
Great. Thanks so much. And thanks for staying on a little bit over their group. Just as we close out, as James mentioned at the start of the discussion, Hector and April and Rob, I thank you for being on the plan advisory for the years, and Rob, definitely for your leadership, and Marcy, welcome to the plan advisory here. And if you folks are interested about the applications that James had mentioned, please get those in. And obviously, any comments like were just mentioned about the SB 260 care continuation considerations, please get those in by the end of the month. And thanks everybody. In terms of the presenters, thank you very much. And thanks to the panelists that raised questions, as well as the general public as well. And with that, James, anything or Jan to close us out here today before?
No, just a thank you to Rick for stepping into the leadership role. And also, I don't think I thanked Rob enough earlier today as I was trying to move through to the transition to Rick. So as my thanks, I'm again soliciting from Rob all those ideas I know he wanted to cover in previous years and we were not able to get to. Now's the time to do it. Send us your list and you'll be top of the list for our considerations there.
Terrific. Thank you. Thanks, everybody. Have a terrific rest of your day.
That makes sense.